Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome back to our series focused on the pivotal role of the GLP-1 receptor agonist in treating obesity. In the previous episode, we did a deep dive into the mechanisms of action and some clinical evidence supporting the use of this drug. We also covered strategies for starting to initiate GLP-1 agonist therapy in appropriate patients. And so we're going to pick up about right there with Dr. Kathleen Wools and discuss best practices for initiating and monitoring and managing side effects and adherence. So thank you, Kathleen, for continuing this discussion with me.
Thank you. I did want to add that one of the things we do prior to initiating is we review patients' labs. And the labs have to be within 6 months of the start date. So if they haven't had labs, as a provider, you can order their labs. You just have to be careful how you code them because a lot of insurance will kick it out. So just make sure that you code for either initiation of a medication, of a weight loss medication, or an obesity code, or just be careful. If you just try to do like a well visit, you're not really a well visit, so it's going to kick the code out. So FYI on that, but we just do basic labs. I don't do all the vitamins and things. I just do basic labs, CMP, CBC, TSH, lipid profile. And then every 6 months to a year, I make them redo their labs. And of course, I always refer them back to their primary care. I'm not their primary care, so they go back to their primary care if they have any issues, concerns, or problems. So make sure you stay in touch with their primary care physician too. So because you don't want to be taking care of them, and it's a little trickier if you're in a med spa. If you're in a private practice, absolutely. But in a med spa, you want to really make sure you're clear on those definitions of role.
Absolutely. So you've initiated, you've done your labs, you've initiated treatment. So how do you continue to monitor your patient progress and determine, those dosage adjustments that are needed?
Well, the nice thing is that on each vial of the product, it tells you how to dose. So it will say, start off at 5 units for a month and then 10 units for a month, or for 4 weeks. Everything is 4 weeks based is the way we do it. Now, sometimes we play with it. So we may start on semaglutide, 5 units, and then the patient's doing really well. So we'll go to 10 units. And then we may do 15, 15, 15, and then we'll go to 20. So we play with it a little bit. There's a lot of cost in it. So I always want to make sure that the patient's aware the higher I dose it, the more cost you're going to have. So we use that as one monitoring thing, how much weight loss they're experiencing. If they're not losing anything, then besides going over their diet and exercise, we also look at our dosing. So to say like maybe you should dose higher, et cetera. We also look at side effects. So some of the side effects, nausea is a big one, and we talked a little bit about it in the last episode. Nausea is going to be their biggest complaint because it's always going to be GI. The food sits there longer. It doesn't digest as quickly. So nausea is the big thing. So a couple of the ways that we can address that is we talk a lot about ginger chews. We talk about those anti-nausea bracelets that people used when they were pregnant. We talk about eating. One of the problems with this medication is you don't always eat. So you can go a long period of time without eating. If you do, you're going to get nauseated. Okay. So we tell people, have a hard-boiled egg, have some, lunch meat rolled up. Right. We really want to push protein and fiber, vegetables, protein, fibers, not carbs, protein, fibers, and water. You have to drink a lot of water because if you don't, you have the potential to hurt your kidneys because you're taking in all this protein, you can get dehydrated. So we talk a lot about that too. So a lot of water, and most people that get nauseated will get nauseated initially. They may be nauseated for a couple weeks into a dose adjustment, and then they'll start to feel better. Okay, so it's not uncommon. One person said to me, I'm nauseated every morning, but when you talk to her, she eats dinner at 5 o'clock at night, and then she doesn't eat again till 9 o'clock in the morning. It's probably too
Oh,
long of
okay.
a span. So then I say,
Right.
well, maybe at night have a hard-boiled egg, and when you get up in the morning, have a protein shake or something. So again, it's
Right.
constantly looking at protein, fiber, water, trying to figure out what works best for them. Some people will just be nauseated in the first couple of weeks they're on the med, and then it goes away.
Mhm.
If they're really, really bad, I do send out Zofran and
Okay.
a diastolic. Not a lot. And I tell people I don't want you to be on this every day, but if it's super, super bad, we'll send out some Zofran initially. Just had a
That's good because I don't like to feel nauseous at all.
and we've not had a lot of takers on it, but we always offer it. So the other thing that's important is if you overeat. So if you do overeat, you are going to get sick on this drug because food's got nowhere to go. And so we tell people you only overeat once. And it usually happens you've lost 10 pounds, you're at dinner, usually there's a little alcohol involved, you have a cocktail, somebody orders dessert, you have dessert, and then you have another cocktail, and then you go home and you're miserable. So you have
Right.
to be careful about that. Vomiting happens, but nobody really complains a lot about vomiting. I told you I vomit after a race. Some people will occasionally vomit, but it's not like anything that's constant, like hyperemesis or anything. It's not like that.
Right. Okay.
Some people will get constipated. If they do, if you're prone to constipation and not drinking enough water, you're probably going to get constipated. So again, we talk about fiber, we talk about magnesium. 600 milligrams over-the-counter magnesium citrate works perfect. And we tell them you fix it when you get diarrhea. Then, stop taking the magnesium. Real simple.
Oh my goodness. Yeah.
Other than that, we've not used anything more than that. People do really well. Sometimes they'll put people on Metamucil just because they're more prone to it. Really, the key is increase your fluid intake. You got to drink a lot of water. Increase your fiber in the diet, avoid fatty foods, avoid overly processed foods, avoid eating too close to bedtime, because if you're going to lay down with a full stomach, you're going to be miserable. And then don't go long periods of time without eating. We tell patients to avoid alcohol. They don't have to, but we tell them to avoid alcohol because they're eating less. Your tolerance of alcohol is not very good anymore because it sits in your stomach longer. So you may have been able to go out before and have 2 or 3 beers. You now can have 1 beer. You may have had a couple Cosmos. You can have 1 Cosmo. So it really changes, and we warn people about that so nobody is surprised or nobody gets drunk. Okay, because
no drinking and driving.
Exactly. So we are very concerned about that. We talk about exercise. Anytime you lose weight, and it doesn't matter, again, if you're on Weight Watchers or Noon or a gastric bypass, you will lose lean muscle. It's just the way it goes. So we tell our patients, you have to strength train. You have to lift weights. However you want to do that, we recommend 3 times a week, at least for 30 minutes. And you got to do weights. If you want to walk or do cardio, that's great. You do not have to do cardio. Walking is a great exercise. Weight bearing helps with osteoporosis, but definitely strength training. You have to strength train. No, swimming doesn't count. Gina, we tell my husband, swimming's not going to count. But things like, any lifting of weights, walking, absolutely perfect, but you have to do it. Some of the other side effects you're going to see is you're going to see hair loss. So, and it's probably more of a nutritional thing. So it's also probably a side effect of the medication. So some people will experience hair loss, some people will not. If you do, we tell them to make sure they're eating enough calories. We always recommend a multivitamin supplement. And normally I recommend prenatals for women. Seems to be a really good vitamin. And then if they still lose weight, we can either put them on Rogaine 5%. We tell them just get Rogaine over the counter. Now, my new thing is Nizoral shampoo. That Ketoconazole shampoo, I started using it. It is amazing what it does for your hair. So
Really?
yeah,
It helps
because
with hair loss?
it stimulates, it actually increases blood flow to the hair follicles. So it's just a side effect of the ketoconazole shampoo. So besides not getting dandruff, it actually helps with hair follicle and hair regrowth. So
Yeah.
I use it now. That's my hair. That's my shampoo. Nizoral. Get it from Amazon. Works perfect. Also Nutrafol. If you want to use any of the Nutrafol products, they're amazing. We kind of stay away from minoxidil and stuff because minoxidil is going to cause hair everywhere. And most women are not interested in growing beards. So we try to shy
No.
away from that and just do topicals at this point. Usually your hair doesn't get horribly thin. You lose some hair, it starts to go back, you're okay. May take a couple months for you to adjust.
Yes.
So we talked a little bit about the gastroparesis. We talked about the ileus. We talked about the bowel obstruction. They have been known to occur. I've never had a patient that had it. I did have a patient that had vomiting. We took her off the med. She's fine, but she had some underlying issues. She had gastric ulcer disease. Again, anything that you question, send them back to their primary for clearance. I've done all kinds of medications, but I still question them. I had a patient who had a fundoplication, and my concern was, well, what if she starts to vomit? Because she said to me, well, I can't vomit. Okay, well, that's going to be a problem if a medication is going to cause you to vomit. Send her back to her gastroenterologist. He said, no, it's absolutely fine. So again, just get clearance. Again, safe and efficacious. Just get clearance. I've never had a doctor tell me no. So, and I actually had a doctor last week because I had a patient with elevated liver enzymes. And I said, you got to go back to your doctor. It's got to be cleared through your primary care. He told her, he said, you have a good provider. He said, I don't know who she is, but he said, she's absolutely doing it the way you should be doing it. And he said, I like her name. I would like to refer her some clients. So again, there's so much not the best way out there doing it. You've got to really think about safety with these patients. We do see some depression. Again, if food's your go-to, I said to somebody, you can't smoke, can't eat, can't drink. What's left? And somebody said, well, you could read a book. I said, seriously, read a book. I got to have one bad habit. So hopefully it's exercise. You maybe become addicted to exercise. Yes. I'm sure you can become addicted to shopping. But if you do have a tendency that food was your coping mechanism, we've now taken that away from you. So we monitor depression very closely.
Oh, that's good. Yes.
Visual side effect. There has been one published report that said diabetic patients on GLP-1s develop some visual issues. They were self-limiting and they did clear. But I always tell my patients, if you have vision issues, follow up with your ophthalmologist if you notice any changes, that there is a side effect of that. So we're very careful about that. We talk about supplements, talk about multivitamins, talk about omega-3s, we talk about D3s. The best advice I can give my patients is eat when you're hungry, stop when you're full, increase your protein, and lots of water. We also address the area of social media. So we talk a lot about what's available on TikTok and Instagram. So I follow a couple obesity specialists. I follow this Dr. Sandra Cortina out of Canada, and she is an obesity specialist, and she takes every study that is done on these GLPs and GLP-1 GILs, and she breaks it down, and she goes through every part of the study. She talks about the validity, the reliability, the specificity, the sensitivity. So I tell my patients, go on Facebook, sign up and follow her. She is amazing. I also include a website, and I can send you that has all of the current research in one spot on these drugs. So they literally will go to this site, and every research article that's been published is on this website. It's https diabetes.medicine-matters.com. And you can scroll through, and it has the step, it's got select, it's got the series trials, it's got everything right there in it. So I make sure that I empower them with websites and tools and resources that are accurate and up to date and also scientific. We talk a lot about the wrong that's out there. We talk a lot about like you need to be educated, you need to be informed. This is not a decision you should take lightly. Everything I just went over with you in these 2 podcasts, I also send my patients in written forms and have them review it all, sign it, keep a copy with them. We give them a diet, healthy eating, a whole diet on what foods are acceptable, which foods, the protein counts in foods. We talk about, my fitness pals. We talk about macros, which I have to tell you, I cannot wrap my head around macros. I can't figure it out. So I've tried all those apps and I cannot figure it out. But we talk to our patients about macros and MyFitnessPal and some other websites. We talk about myplate.gov. We give them websites. We try to give them every tool I come across. Any research article I find out or any new breaking thing on these medications, I quickly look at the validity and efficacy and specificity and sensitivity of the trial to make sure it's appropriate or not. I'm constantly updating my information, making sure it's current, making sure that, and I tell my patients, I am telling you everything we know today. That's all I'm telling you. I don't know what we're going to know tomorrow, but as of today, I can guarantee you this is everything we know. I also tell them that this medication is in the masses. It is estimated 300 to 500,000 people in the United States are on this medication. It is in the masses, which means we have a great sample size and we're not seeing any more problems. Okay. And that's really great because if we, like fen only went to the masses in a very small study before we had big issues. So it's great that the more we see about these meds, the less we're seeing issues with them. We have no long-term studies. The medication's maybe been used in diabetics for 10 years at the max. So we don't have any data that talks about further than that. Every data, all the studies that have been done have been very positive. And again, as the new studies come out, I go out and I vet them before I will share them with any of my patients, just to make sure that we're all kind of knowing that the information is scientific. So yeah, that's kind of it in a nutshell. We cover a lot.
Yes.
Yeah, we do. And I will tell you, I always have patients say to me, they are appalled when they go back and talk to their friends that are on the drugs, how little they know about it. They said, I pull out my paper and I say, well, according to Dr. Wools, you're supposed to, and they're like, well, nobody told me that. Nobody told me that. I just really believe the more informed they are, the more empowered they are to do this in a safe manner.
Absolutely. And that's so much information for them. That's a lot to take in. So I love that you give it to them paper as well, so that they can just be like, I just need to digest this. That's a lot.
Right. I want them to listen in the first visit. Then I want them to read it. And then on their subsequent visit, I want to discuss any concerns that they have.
Absolutely. All right. So you have, you've educated your patient. They've decided to start it. You're working through how to do their adjustments. Now, what about when they lose that weight that they're looking at losing? How do you transition them to like a weight maintenance rather than a weight loss?
Most patients will almost do it on their own. So whatever dose they're on, you're always looking at what their weight is. So let's say you're on 40 units. Okay. You've been on 40 units for 2 or 3 months and you are maintaining your weight. You're not gaining, you're not losing, but you're maintaining. We will keep them on that dose. Then it's up to them to make the decision whether they want to continue or they want to start weaning themselves down. You don't stop the medication abruptly, you wean them down. And again, hopefully through the course, because the average person is on this drug about 18 to 24 months. It's not a short-term course for this medication. It's not like 3 months, 6 months, and you're off. They really do recommend that you stay on the drug for at least 18 months. This Dr. Sandra Cortina says, eventually we're going to see this medication used for their whole life. She said it's going to be just like hypertension, diabetes. Once you're diagnosed with this obesity, you are going to be taking an obesity drug the rest of your life. It's going to be the management of obesity. So she really believes that we are eventually going to transition to that. She also believes that eventually insurance companies will recognize obesity as a disease because in the United States, besides the state of Massachusetts, which has Harvard Obesity Center, we still consider obesity a psychological process that you can stop at any time if you would just stop eating. Just stop it. And again, It's mostly women. So, that's a whole nother lecture. So just kind of be aware that we've done nothing to improve how we're dealing with this medication. So maybe eventually we'll get there. So it's really up to the individual. So we tell them, you can maintain on it. It's an expense. You have to determine how much money you want to put into that. And I've had patients that have been on it for a while, lost their weight, weaned off of it, and have been very successful. I've had patients that have been on it for a while, weaned off of it, and gained some of their weight back. But I've had patients that have had bariatric surgery that have come to me and now have started the med because it's safe to use after bariatric surgery, which is amazing. So again, I have patients that have been through weight loss their whole life. And the more and more research that's being done on weight loss, you're starting to identify that it really is a genetic component, that you cannot eat anything and still be morbidly obese. This is not something that it's because you ate too much McDonald's. There is a genetic component to this. So I think as we kind of navigate it and look at more research, we're getting into a better field. And now the drug's being studied to look at addiction for alcohol, look at addiction for drug use. So again, this is going to be a far-fetching, reaching type of medication. It's if used appropriately, you can wind up with the whole antibiotic overuse if we're not careful. It has to be appropriate.
Absolutely. Well, I want to quickly kind of talk about the special populations and patient factors to really consider that can cause contraindication for use or maybe require some extra caution.
Right. So there are some. So when we talked about the pancreatitis, if you have a straight causative effect like a Depakote use or something, then that patient, again, once cleared by their PCP, all of this would be cleared by their PCP. They could actually then take the medication. I've had patients that have thyroid nodules. The majority of us probably have thyroid nodules, and until they get big enough, we don't know, or we have a scan. I checked with all the obesity specialists I know. I've looked at the research. Thyroid nodules that are not growing is not a contraindication. Okay. Hashimoto's is not a contraindication. So I think we need to educate ourselves because some of the things we think, this is going to be a contraindication is not. Mental illness of anorexia and bulimia to me is a contraindication, or to me needs to go to an obesity specialist. It's beyond my scope of practice. So I think there are things that we as practitioners will decide, like for this group, I really believe under the age of 18, you need to be with a specialist. I am not a specialist for that age group. Birth control pills. If you take birth control pills, this will affect your absorption of birth control pills every time you increase your dose. So you kind of got to tell people you can get pregnant on this drug. If you get pregnant, it's contraindicated. So it does not affect, though, thyroid levels. And it just seems right now to be birth control pills. So every patient, I have that conversation. And there was a study published not too long ago that said increasing birth rates related to Ozempic. And it's because...
I was just thinking that.
Exactly. It's because if they are on birth control pills, they are now going to get pregnant. So something to think about. Surgery, any exposure to anesthesia. It used to be 24 hours fasting. This drug keeps food in your stomach much longer than that. A colonoscopy is a week or two, depending on your anesthesiologist. So I always tell my patients, you have got to inform everybody you're on this drug. And it's really a slippery slope. People are very embarrassed by obesity. They're very embarrassed that they can't control their intake. And then they become very embarrassed, or they suffer from shame because they're on this medication. I yell that I'm on this medication from the rooftops. Do you know what I mean? If you want to judge me, you go right ahead. I also use Botox, filler. I exercise 5 days a week at the gym. There's plenty to judge me for. Do you know what I mean? Stand in line. And it's okay, because there's always going to be somebody who's going to judge. So patients sometimes will be very reluctant to share this, but they have to share it with every provider. Your risk of vomiting and aspiration is so great on this medication. So I always tell them, as soon as you have that initial appointment for your colonoscopy or for any other surgery, one thing you have to say is, I take this medication. Most providers, anesthesiologists want you off at least 1 to 2 weeks.
Oh, okay. So it's not
Yeah.
even just a couple of days.
No, it's 1 to 2 weeks. Yeah. So if you know someone's going to have surgery, then take them off of it. The other really interesting thing that we just went through that I wasn't even aware of until it just happened to me was Ramadan. So I have a Muslim population. And so I had patients that wanted to start this medication a week before Ramadan. And it was like, no, we can't do it, because my fear was the renal side effects due to the fact that they were going to be so dehydrated. Now, I understand people that fast, they know how to do it. They can go all day without eating. They can handle it beautifully. If they were diabetic, they would still be on the drug. My thought was, why go down that road if we don't have to, if we can just wait the 30 days of Ramadan and then start you on the medication? So I talked to several people that were members of the mosque. I talked to several people that were outside the mosque, experts in the area. And we kind of just decided that for safety reasons, we will not do it. Now, of course, if they were diabetic, that's entirely different. So again, that was a population I didn't even expect it to be an issue. And there will be other ones. There are people that genetically get rashes from the medication, something about their back feels like they're on fire. It's not a reaction. It's just kind of waited out. It gets better. Some people get hives.
Right.
I don't know. I'm more cautious. If you have some funky side effect, I kind of take you off of it. I'm a little more nervous. But I think as more studies come out, we'll get better at it. But right now, I don't want anybody to have anaphylaxis. There's also a certain population that will never respond to this medication. It's like 1 to 5% of the population. So you need to tell them that you may not respond to this medication. It may not change your life at all.
Now, is that response for weight loss and or the role it plays in diabetes management?
It may potentially be both. And it's just, and there's no rhyme or reason. I had a patient who was on every med, every dose, never lost an ounce. And we went over her diet. We went over her exercising. We did everything. Sometimes you can supplement. If they're at the top of their dose, we can supplement with metformin. We may try some phentermine. We may do topiramate. Sometimes we play a little bit to see if we get a better reaction. And sometimes they just don't respond. And the problem is once you buy, we individualize our vials. We don't buy like a gallon. We buy them per patient so we can track lot numbers in case there's any outcomes. And I would encourage everyone to do that. It's a little more expensive, but if something bad happens and you're not accessing a vial 100 times, kind of causing any bacteria, I don't care how good your technique is. So we do individual vials. If they bought the vial, they're out $600. You know what I mean? So sometimes that's another little issue but I always give them the vial and say, you can give it to whoever you want. I just can't be responsible for it. So, yes, it's kind of for some patients, there's always going to be those few.
What about adherence? What are some tips that you have to help with improving motivation of use, which it seems like if you're seeing results, you're not going to have issues with motivation, but you do have some that, just forgetful, you just forgot to use it, or, they're not persistent in using it correctly.
They usually will quit on their own. I had one person who bought a vial, did 1 month of shots and decided she didn't like it. She just wasn't going to do it. She didn't like it. She'd rather be on phentermine. She wanted that amphetamine component, which this medicine does not have. Do you know what I mean? You're not going to feel this surge of energy. If anything, you may feel a little fatigue. We give you vitamin B12. Do you know what I mean? So some people will feel fatigue more than anything. So I think I told you some people I can give their vial and their medication if they're healthcare and they'll do their own. Some people I give them 4 syringes. They come in, I weigh them every month. I give them 4 syringes, adjust their dose accordingly, monitor them, and they go home for a month and come back. And I do have one patient who comes in every week and I give her a shot. So I'm all over the place. It just depends on what works best for the client. And that's what we tell you. What works best for you? They are pretty good about following their diet. Where I really have to stay on them is the exercise. It's really encouraging them all the time about the exercise. You can, my sister has this term called fat skinny. And she's always like, well, her problem is she's fat skinny. And she's right. You can be fat skinny. So we talk about that and the importance of exercise to prevent that. And usually what happens is they see that they're fat skinny, and then that scares them into following the exercise guidelines. But that usually probably is the thing they're least compliant on, is the exercising part.
So we're titrating up, but now if I want to quit, am I titrating down?
Yes, I would titrate you down depending on your dose. If you're only at 5 units, not a big deal because that's the initial start. But if you're at like 40 units, we'd probably go 40, 30, 20, 10. We may do it over 6 or 8 weeks. It may not be a month of each one, but we definitely would do a good 2 weeks to titrate you down. And then your body isn't thrown into, from not eating at all to now wanting to eat everything. So
you're going to have to plan that out if you're going to have surgery, right? So if you're going to be put under
normally
anesthesia.
For surgery, they'll just stop it for 2 weeks.
Okay.
They'll just stop it. Again, you just have to be aware that you may be really hungry during those 2 weeks. But for surgery, they just stop it. They don't care what your nose is. You're off that bed. So
you're done.
Yeah, you're done. You're done. And some people will play, sometimes I play with it, like instead of doing it every week, I do it every 10 days because, it's Easter. So, and you're not supposed to do that. I'm not sanctioning that in any way, shape, or form. I'm just saying, you've got to look at this in the real world also, and I can tell you this is exactly, it's kind of like health literacy. This is exactly the way you're supposed to do it. We're hoping you do it for 75%. So know what the side effects are for that 50%. Do you know what I mean? So that you can address them in your clients when they present with that, because they will present with that. Travel is another issue. It has to be kept in the refrigerator or freezer, depending on the product. So we talk a lot about traveling with syringes. No problem, but we have to talk about it, because they don't really have a vial. They just have 4 syringes, and it has to be kept cold. So we talk about thermoses and those kind of things. So there's just some things that you have to have in conversation with patients so that they're aware that these are medications. We talk about the Ozempic face. We talk about Botox and fillers. You're not going to be happy. And we're running a special on Botox. No, just kidding. And being a med spa, you can kind of like, feed it to like the next thing. But it's true. I told you, we all need little, enhancements. So, because you lose fat. So, so
that's a lot
of pieces.
So much to cover.
There's a lot of
pieces to this. So as we are kind of running out of time here for this episode 2, is there anything that you just want to make sure you emphasize to our listeners?
Education. Make sure you are educating your patients. Make sure they are informed. They know exactly what they're getting into. Make sure you've covered the safety and efficacy of this drug. Don't look at just the reward, even though we all want to be millionaires. Look at how to do it safely. Vet your own people. Make sure your products are as safe as they can be. You may not be the cheapest, but I probably have 25, 30 weight loss clients in a couple months. And it's just because I am very safe and people like that. I'm as safe as you can be today. So really make sure safety, efficacy, education, and monitor them. Really it's like it wouldn't be any different if they were a diabetic. And I think that's what you have to think about. This is a prescription medication. It should be respected as such.
Absolutely. That's such great advice. Thank you so much, Dr. Kathleen Woltz, for joining us for this series.
Thank you. I loved it. And if anybody has questions, they can always reach out to me. I'll be happy to mentor, help people, share all my information with you. Anything I can do to help you be successful.
Absolutely. Girl, you packed so much into these. I didn't even have to talk much. I was just like, I need to take notes. So much information here.
It is. I told you I spent at least an hour consulting with each patient prior to even starting the drug. I just want them to be informed about it.
Absolutely. Well, thank you so much for sharing such a wealth of information, because I know I am, and I hope our listeners are also walking away with such a comprehensive understanding of how to leverage these drugs as part of, really an evidence-based treatment approach for patients and looking at weight management and, treating obesity. So these medications have definitely emerged as powerful tools. And they're just such a great way to help really with that dual challenge of elevated blood sugar and what its effect is on weight loss.
Absolutely.
I mean, they go hand in hand.
Absolutely.
And a lot of times we don't realize that. So thank you so much for opening this up for us. And it was great to meet you and discuss this with you. And to our listeners, I encourage you to explore many of the courses that we have available on elitelearning.com to help you grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.